Right, so from this slide onwards, we'll be talking about peripheral chemoreceptors. Now, peripheral chemoreceptors, unlike central chemoreceptors, have a few twists and turns in the story. They're not really straightforward. And before we delve into the nitty-gritty, I would like you to keep in mind three things. Their role in hypoxia. We know what hypoxia is, the deficiency of oxygen. Their role at the onset of exercise, moderate exercise. And then finally their role in metabolic acidosis. So just log it away, put it on the side of, scribble it down, or keep it in the back of your mind. These three things, we'll be discussing these three things. We need to understand what is the role that they play in hypoxia at the onset of exercise, or let's say exercise, and in their role in metabolic acidosis. Okay, so the location, let's get this out of the way first. Their location is, as we mentioned, unlike central chemoreceptors, they are called peripheral chemoreceptors, and so peripheral chemoreceptors need to be present peripherally. So this is where they are. They are at the bifurcation of the carotid arteries. Here, right here in the middle, you will get a bunch here. We call them the carotid body, and then you will find them tucked underneath the arch of aorta, and these are called the aortic body. So carotid bodies, these are peripheral chemoreceptors placed here, and then you have the aortic bodies, you have peripheral chemoreceptors present here as well. And as mentioned in the elaborate electricity example initially, at the beginning of this lecture series, these are connected by nerves to the central nervous system, the respiratory centers. Right, so peripheral chemoreceptors. When we discussed central chemoreceptors, we talked about the role of hydrogen ions and PCO2 as the main stimulants of central chemoreceptors, and that oxygen did not have a role over there, if you remember. So what about peripheral chemoreceptors? So the first thing is PO2. This is where oxygen comes in. So a drop in PO2. But you will notice a peculiarity as well. If you remember, the normal value of arterial PO2 is around 95 mmHg. We round it off to 100, right? But what is this here? It says that a drop in PO2 to this remarkably low range, this happens to be the main trigger, the main stimulus of peripheral chemoreceptors. What happens between 100 and 60? Question mark, question mark? Well, the simple answer is nothing. Nothing happens. So, if you drop the PO2 of arterial blood from 100 mmHg to around 60, peripheral chemoreceptors will not respond. And if you can connect this dot with another dot, oxygen has no role to play in central chemoreceptors. This is an interesting point, if you agree. So oxygen has no role in the central chemoreceptors, and it seems to have a very peculiar short-range role in peripheral chemoreceptors as well, or only, not as well, only. So it's silent over a huge drop of PO2 from 100 to 60, but below 60, yes, it then stimulates vigorously and very aggressively, and during even one breathing cycle, it enhances respiration between this range. But above this, it's not picked up. Any ideas why this would be the case? We will talk about this in a bit in the next slide. But one thing I will again remind you, that due to the buffering style and the buffering potential of the hemoglobin molecule, remember the hemoglobin oxygen delivery system that we talked about earlier as well, it is designed so brilliantly that even a drop of from 100 to 60, can you imagine the PO2 being dropped in this such a remarkable fashion, doesn't really dent the hemoglobin oxygen saturation. From the top of the head, you will recall that around 75% hemoglobin saturation around even this, around this or a bit more PO2, the hemoglobin is still saturated 75% with oxygen, which is a pretty decent figure considering how low the PO2 is. So again, the answer partly answer is not the answer, but there are no bad effects of the drop of from 100 to 60 in at least the oxygen delivery to the tissue, because not because of peripheral chemoreceptor, because they are not working in this drop, but because of the hemoglobin oxygen delivery system that is brilliantly designed so that this whole thing is buffered. So in summary, the number one, well, relatively speaking, the number one stimulus of peripheral chemoreceptors is a drop in PO2. We saw the range. And isn't this called hypoxia? Remember, I asked you to put the three things on a side. Number one was hypoxia. So peripheral chemoreceptors, their response to hypoxia is a university question. It's a very important MCQ, and this is part of the information that we want you to know about this. What happens below 60? Why do they not respond from 100 to 60 drop? We will talk about it in the next slide. And below 60, they are very active, very sensitive to hypoxia. Every degree drop below 60 is responded very smartly by an enhancement, a stimulation mediated from these peripheral chemoreceptors right into the respiratory centers to enhance respiration. That is right now what we will talk about, the PO2. Next up is PCO2. Again, the effect, very importantly, this is an important point, the effect that PCO2 has on the central chemoreceptors, that is exquisite, that is very, very strong and direct. On the peripheral chemoreceptor, it's not the same quantitatively speaking. However, it is rapid, and we'll talk about that in a bit. But you need to see that as compared to the effect that the PCO2 has on central chemoreceptors, the effect on peripheral chemoreceptors is not that much in comparison. However, it's rapid. Now, this is something that I mentioned earlier. Again, asked you to scribble something away. One was hypoxia. Second was exercise onset. So when you have started your exercise, what starts happening is exercising muscle increase temperature, increase various ions, and increase hydrogen ion concentration, right? So and of course carbon dioxide. So when these tissues start producing carbon dioxide, that carbon dioxide at the exercise onset affects the peripheral chemoreceptors to stimulate the respiration through the central nervous system, such that the enhanced respiration can help you exercise more and better and efficiently. So this is the role of peripheral chemoreceptors that they play in exercise. Lastly, we have increased hydrogen ions themselves. So increased hydrogen ions also affect peripheral chemoreceptors. However, there are a couple of things that you need to understand about this. One is that this effect is independent of this effect. Why did this have to be clarified? Because in central chemoreceptor situation, you have both of these things together. It's the PCO2, if you remember, which yielded hydrogen ions. So these are connected when we are talking about central chemoreceptors. But when we're talking about peripheral chemoreceptors, the effect of hydrogen is independent from carbon dioxide. Carbon dioxide does not have a spectacular thing in the regular day-to-day control of respiration. It has a special role in exercise onset. Here, however, the hydrogen ion is independent of carbon dioxide, and it directly stimulates peripheral chemoreceptors, but not both. It does not affect the aortic peripheral chemoreceptors. It almost exclusively stimulates the carotid peripheral chemoreceptors. Something to note, this is a peculiarity. So hydrogen ions stimulate this type of peripheral chemoreceptors. They are independent of PCO2, so they have an independent effect. And thirdly, what is metabolic acidosis? Well, very briefly, metabolic acidosis is to do with a derangement of kidneys such that the net accumulation of hydrogen ions over bicarbonate is more. So you have a situation where the kidneys did not do their job, and now the body has excessive hydrogen ions and less alkali. The result is acidosis, and this acidosis is of the metabolic kind. If you want to remember it, remember metabolic has to do with kidney, as opposed to respiratory acidosis, in which the culprit is the lung. Here the culprit is the kidney. Anyway, so in metabolic acidosis you have increased hydrogen ions, and when you have increased hydrogen ion circulating in the blood, they then stimulate carotid body peripheral chemoreceptors. They get stimulated and they increase the respiratory rate through their effect on the stimulation of the CNS centers, respiration centers. And this is that increased respiration which you will study when you study metabolic acidosis in renal physiology. That metabolic acidosis leads to increased respiration as a quote-unquote compensation. Why compensation? What has increased respiration got to compensate acidosis? How will it compensate for acidosis? Well, now remember, if you are increasing your respiration, what are you doing? Focus on expiration. What are you blowing off? Extra carbon dioxide? Yes, carbon dioxide, from your knowledge of chemistry, you would remember that it is volatile acid, yes, as opposed to fixed acid such as sulfate based or chloride based acids. Carbon dioxide based acids are volatile, you can exhale them. So when you have increased the respiratory rate, you get rid of more carbon dioxide. You get rid of more carbon dioxide, it basically indirectly means that you are getting rid of acid. So in metabolic acidosis, the hydrogen ions through the carotid body enhance the respiration so that more carbon dioxide is exhaled, and the PCO2 drops in the blood. It helps the pH of the body. Again, it's a compensation. You need to note this. It's a compensation. It's not a treatment. So it doesn't bring the whole thing back to normal. We don't expect that, and it doesn't happen like that. But it's a compensation so that things don't go very awry, very bad. It's still within some physiological limits. That's the introduction of peripheral chemoreceptors. Again, it's a tricky subject. You need to study it from Guyton. I would say you should add Guyton to your studies as well. And of course, you can ask a question here or via WhatsApp if there is a problem. If I were your examiner, I would certainly ask you about peripheral chemoreceptors, because this is how you check your knowledge of their role in hypoxia, their role in exercise, their role in metabolic acidosis. I just posed this question, a drop in PO2 between 100 and 60, no significant effect on ventilation, why? And this is the answer. These 2 points we will just go through these 2 points. Number 1, very briefly, very simply, deoxygenated hemoglobin is a weaker acid than oxygenated hemoglobin. In other words, when you have hypoxia, you have less oxygen content of the blood, so more hemoglobin is without oxygen than under a normal situation, right? And you have just learned the nature of hemoglobin is it is a weaker acid without oxygen. So without oxygen means we are discussing hypoxia, so oxygen is less, and most of the hemoglobin will have no oxygen to be with, and that renders it to be a weak acid. You can simply say that the hydrogen ions content of this blood is less than normal. So it's less quote unquote acidic. Now if you quickly go to the list of stimulants of peripheral chemoreceptors, you will know that hydrogen ions have a significant effect on peripheral chemoreceptors. So here you have a blood which, although it is deficient in oxygen and is supposed to stimulate the peripheral chemoreceptors, and which it does actually, but because the hydrogen ion concentration at the same time is less than normal blood, whatever little instigation or stimulation this hypoxic blood would have had on peripheral chemoreceptors, that is neutralized by the lesser number of hydrogen ions in this blood. Okay, so I will recap the whole thing again. Hypoxic blood between 100 to 60 mmHg does stimulate peripheral chemoreceptors, but that stimulation is not very strong, and whatever that stimulation it is nullified by this phenomena, and this phenomena is that hypoxic blood acts as a weaker acid as compared to normal blood, and hydrogen ions are less, so the proper stimulation of peripheral chemoreceptors cannot come into play because these two things nullify each other. All right, that's one thing. The second thing is again the same story, that when whatever little effect of this drop in oxygen content of this blood did have on peripheral chemoreceptors, and there whatever slight increase in ventilation that did actually occur even after this whole the first effect of the weak hydrogen ions, the slight increase in ventilation is again neutralized by the drop in PCO2. So whenever you have a slight increase in ventilation, you blow off extra carbon dioxide, which brings the ventilation rate back to normal. So in this case, whatever little effect this hypoxia had on ventilation, it increased ventilation through peripheral chemoreceptors. Extra carbon dioxide was blown off, and you know that at sea level carbon dioxide is the main controller of respiration. So this decreased PCO2 then affected the central chemoreceptors and inhibited them. This is from the discussion that we had on central chemoreceptors. So these are the 2 points which basically show us that a drop in PO2 from 100 to 60 does stimulate peripheral chemoreceptors, but at the same time there are 2 enemies of this stimulation. These are the 2 elements which nullify this effect that oxygen has between these pressures. And this is a nice one-liner. The stimulatory effects of hypoxia on ventilation are not clearly manifest until they override the effects of hypoxia override the above 2 counterbalancing effects. So In this slide, we discuss another peculiarity of peripheral chemoreceptors. Now we are coming to the fag end of this topic. Right. So the blood flow to each carotid body, to each peripheral chemoreceptor, is very high, especially the carotids. You can imagine, if you appreciate the location of these receptors, the carotid ones are, of course, they are located at the bifurcation of the carotid arteries, while the aortic ones are tucked underneath the fountain of blood, aorta itself. So you can imagine the blood flow per amount of tissue, per weight of tissue that these very small bodies would be receiving. So a lot of blood, but the size of the organ is so small. So if you were to divide the amount of blood with the amount of tissue, it would be a spectacular figure that comes out. And here are some comparisons you will appreciate. So peripheral chemoreceptors generally on average receive about 2000 ml per 100 gram of tissue. So each 100 gram of tissue is receiving 2000 ml of blood. To put this into context, the brain receives 54 ml only per 100 gram of tissue. If you are a first year student, you will have even lesser blood. That was a joke. Okay. So again, peripheral chemoreceptors receive, for every 100 gram of tissue, they get 2000 ml. The brain gets only on average 54 ml per 100 gram of brain tissue. Kidneys, they receive about 420 ml of blood per 100 gram of tissue. This gives you the context. The implication of this is extremely important. Now, you would remember that oxygen is carried in blood in two forms. One is the dissolved form, which is very less. If you remember, it's only 3% of total oxygen content of the blood that is carried as dissolved oxygen, while 97% is bound oxygen with hemoglobin, right? You remember that. So with peripheral chemoreceptors, the blood flow, the physical blood that goes through the receptor is so much, it's so high, that just the dissolved oxygen is enough to provide the nourishment, the need of these small organs. So they derive, in other words, they derive their oxygen needs from the dissolved component of the blood, not the hemoglobin bound component of the oxygen. Now this leads to some very interesting scenarios. These are the three scenarios. Again, if I would set your university paper. I don't. Just an example that I'm using. I would certainly trouble you with one of these scenarios. Okay. So be very careful in thinking about these scenarios. Again, there are no easy pickings here. I will not give you the answer here. I would wait for you to comment in the section. Please be precise. Use the name of the condition, and briefly in 1 or 2 lines just describe what you think would happen to the peripheral chemoreceptor activation in number 1, anemia, number 2, carbon monoxide. This is carbon monoxide poisoning. We've spoken about this. My students who are of this college, who have had my lectures when the world was a normal place, pre-COVID infection, we talked about this a lot. And then very interestingly, cyanide poisoning. So you would want to look this up. These 3 scenarios are very important. This gives your knowledge a holistic touch. It's applied. It would be nice if some of you at least get these 3 right.